So welcome everyone to the first session of the abstract presentations. So for those who I haven't met yet, my name is Sham. I'm a biostatistician at the University of Melbourne. So in this first session, we have 4 amazing speakers. So we've got Anurika and Vanessa, who will each speak for 15 minutes. And then we have Melissa and Fernando, who will then talk for 5 minutes each. Just for the speakers, I'll give you when you've got 1 minute to go, I'll just flag that in the chat for you. For everyone else, if you've got any questions, please feel free to post them in Slack under the main hall, and we'll get to the questions at the end. So I will hand over to Anurika, who's going to be presenting about performance of interim analyses in a 2x2 factorial design with a time to event outcome. And this is a simulation study of the VAPOR-C trial. So over to you, Anurika.
Thank you, Shamwa. I'll just start by sharing my screen. It says I'm not able to share my screen. I think you need to enable.
Try again, sorry. You should be able to now.
Okay. Right. Can you see my slides?
Yes, thank you.
Yeah, good, thank you. Hi, everyone. Good afternoon from Melbourne. I would like to start by acknowledging the traditional custodians of the land which I'm on, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past and present. I would also like to extend that respect to any Aboriginal and Torres Strait Islander peoples here today. I'm Dr. Anurika De Silva, and today I will be talking to you about the performance of interim analysis in a 2x2 factorial design with a time to event outcome. So I would like to acknowledge the fantastic work by my brilliant colleagues, Meg Tully, Yu Yang, and Sabina Brott on this project. And this work was funded by University of Melbourne ECR grant and Austrian seed funding for methodology research work grant as well. Right, so as we all know, we monitor accumulating data during RCT to stop the trial for either early superiority or futility. And these repeated looks at the data are often guided by statistical stopping rules such as Habital-Peto or O'Brien-Fleming, for example, to maintain the overall type 1 error and power. Now, while the use of these stopping rules are well documented for parallel group RCTs, there's limited guidance in the literature for RCTs with a factorial design. So our project was motivated by the VAPOR-C trial, which is a single-blind RCT with a 2x2 factorial design, which investigates propofol versus sevoflurane and lidocaine versus no lidocaine infusion. The primary outcome of this trial was disease-free survival following major cancer surgery in patients with colorectal cancer or non-small cell lung cancer. We designed this study expecting a sample size of 3,500 patients or 850 events. The study was powered at 80% for a hazard ratio of 0.8, which we assume to be the same for both comparisons. We follow up patients every 12 months post-surgery for 3 years, and we have planned for 1 interim analysis at 50% of expected events using the Habital-Peto stopping rule. And the purpose of this project was to define the operating characteristics of this interim analysis. So the overall aim was to examine the performance of this Habital-Peto stopping rule in a 2x2 factorial design with a survival outcome and a single interim analysis at 50% of the planned number of events, so mimicking the VAPOR-C trial in a simulation study under the scenarios of no synergistic or antagonistic interaction. So we wanted to particularly investigate the probability that a trial is analyzed as factorial or multi-arm after testing for interaction, and also the type 1 error rate and the power under the testing strategy, which I will discuss in a few minutes. Now, before I get into the testing strategy and the simulation design, I just wanted to bring up this paper by Brennan Kahan, published in StatsInMed in 2013, which discussed about the bias in factorial trials. So in this paper, Brennan discusses how factorial designs or studies with factorial designs are often underpowered to detect an interaction. So this two-stage approach, which I'm going to discuss next, often leads, even in the presence of an interaction, will often lead to a factorial analysis, and therefore doesn't recommend this approach. And there are other limitations such as inflated type 1 error and bias associated with it, which I'll discuss once I get to the results of our study. But as I mentioned before, there is no guidance in the literature on how we should go about defining the operating characteristics of an interim analysis done for a particular trial, and that was the purpose of using this method. So before I get into the two-stage approach, I'll do a quick description of our simulation setting. So for convenience, I'm just going to refer to our 4 groups as only A, only B, and the combination of A, B, and placebo. So we started by simulating the time to event using the baseline hazard ratios, and the interaction. And for the purpose of the final analysis, we censored the patients at 3 years, shown by the black solid line. And we identified events as patients with a survival length less than 3 years. So the timing of the interim analysis was identified when the number of events reached 50% of the expected at final, which is shown by the black dashed line. And for the purpose of the interim analysis, the patients were censored at this interim time point. So next, I'm going to take you through this two-stage approach that I mentioned before. So what happens here is, first at the interim time point, we will test whether the treatment interaction is significant using a cutoff point of 0.1. So if there is a significant treatment interaction at interim, then we will analyze data as multi-arm. What this means is that we will compare each active arm with the placebo. So we will test whether the treatment effect is significant at interim using a threshold value based on the Havital-Peto stopping rule. And if it's significant, we will drop that active arm. If not, we will continue with that active arm. Now, if there is no significant treatment interaction at interim, then we will analyze data as factorial. What this means is we will compare A with no A, or compare B with no B. So again, we will test whether the treatment effect is significant at interim using a threshold value based on our stopping rule. And if it's significant, then the comparison is further stratified by the other treatment group. For example, we'll compare only A with placebo and AB, the combination of AB with only B. If both treatment effects are significant, using the same threshold value, we'll drop that particular arm. If not, we will continue with that. So this slide nicely summarizes what we observe at interim, and based on the decisions that we make, what happens at final. So for example, if you look at the right-hand side panel, we can see that if there is no significant treatment interaction, then we will analyze data as factorial at interim. And in that case, if all active arms are dropped at interim, then of course we'll stop the trial. If either A or B is dropped at interim, that means we'll analyze data as 2-arm at final. If we proceed with all active arms at interim, then we will conduct an interaction test at final. So if our decision leads to the point that we are to conduct an interaction test at final, then similar to before, we will test whether this treatment interaction is significant at final. And then if there's a significant treatment interaction, we'll analyze data as multi-arm. And if there's no significant treatment interaction, we'll analyze data as factorial at final. So that's basically a summary of this two-stage approach. Now, this is a summary of all the scenarios we have looked at so far. We've got all the interaction factors and the hazard ratios we've considered for our simulation scenarios. On the left-hand side panel, I've shown the percentage of simulations analyzed as factorial at final. And on the right-hand side panel, we've got the percentage of simulations analyzed as multi-arm at final. And what we can see that as expected, as the interaction factor moves closer to the null value of 1, which means when there's no interaction, a higher percentage of simulations are analyzed as factorial, which is what we would expect. And as the interaction factor moves away from the null value of 1, a higher percentage of simulations are analyzed as multi-arm at final. And there's a probability of around 10% of detecting this interaction, which is what we would expect. So moving on to the results, this slide gives the results for the simulations analyzed as factorial at final, resulting in a significant treatment effect for A at interim or final. And just to mention that we observed similar results for the treatment effect for B as well. Now here we can see that as expected, if you look at the gray box in the middle, we can see that the type 1 error rate as expected is around 5%. So just to understand the patterns we see with the percentage of simulations on the right-hand side panel, I've also given the theoretical effects, the underlying theoretical effects, so just to better understand these patterns. So as I mentioned, the type 1 error is around 5% as expected. And if you look at the row across this interaction factor of 1 or the null value, the power is around 80%. And if you look at the bottom left and the top right-hand side quadrants, which is the synergistic interaction, we can also see that a higher percentage of simulations are analyzed as factorial. So far, the simulations are performing or behaving as we would expect. Now, this is where the limitations of this approach starts to show up. So this slide shows the results for the simulations analyzed as multi-arm at final, resulting in a significant treatment effect for only A at interim or final. And again, we observed similar results for the treatment effect for only B as well. So if we look at the row across on the right-hand side panel, the row across the null value for the interaction factor, we can see that the power is around 55%, which is what we would expect for a scenario like this. But if you look at the type 1 error, we can see that it's quite inflated at around 25%. And as I mentioned earlier as well, this is a limitation of this approach, this highly inflated type 1 error. This is mainly because the interaction effect and the individual treatment effects for only A and only B are highly correlated. So we could expect, or we would expect these inflated type 1 errors. But this is only relevant to these individual treatment effects for only A and only B under this multi-arm scenario, and is not really relevant to this combination treatment for AB. So we can see this slide gives the results for the simulations analyzed as multi-arm at final, resulting in a significant treatment effect for the combination of AB at interim and final. And we can see that the type 1 error is back to the expected value of 5%. So this is what we observe with this two-stage analysis approach, given our simulation study. So given our observations, what we have proposed so far would be to make some changes to the DSMB charter. One thing was to raise awareness of the behavior of this type 1 error and to alert the DSMB of the expected bias and the inflated type 1 error that we can expect with the proposed two-stage interim analysis approach. And also, if you can remember, as I mentioned, the last step of the two-stage analysis approach was to test whether the interaction effect was significant at final if we were to conduct an interaction test. But however, there are many limitations and criticisms against this approach. So what we would proposed is to again alert the DSMB to this limitation and also present data for the two main effects and also for the multi-arm analysis as well. And along with this, we will also describe this two-stage testing strategy approach in detail for the interim analysis. And that is how we hope to define the operating characteristics of this interim analysis. So currently we are writing up this work, and we hope that it would be helpful for anyone considering conducting an interim analysis for a RCT with a factorial design. But there are some other aspects that we are considering as future work. Given the limitations of this two-stage proposed testing strategy, we are thinking of other variations that we can probably incorporate into this testing strategy. And as I mentioned before, for the simulation study, mimicking the VAPOR-C trial, we assume that we have the same effect for both comparisons. So we might consider differing this effect. And for now, we assume that all patients are recruited at the same time point. So we might consider different recruitment patterns, even though we think that if we are able to finish recruitment within the first 3 years, this might not have a big impact. We might also consider multiple interim analysis, because we observe that if we have multiple interim analysis, different stopping rules might start behaving differently. And also the final point was looking at bias and other operating characteristics more carefully in these scenarios. That's all from me. Thank you very much.
Thank you, Enrica. That was great. Great presentation, and I liked your diagrams. They were easy to understand. So thank you.
Thank you.
I'll move across to see this. I can't see any questions yet, but please feel free to post some. I have one actually, Enrica, for you. I noticed, so this is obviously time to event outcome. Could this be looked at in the setting of competing risks? And how might that look, I guess, is my question.
I think it can be adapted to the scenario, but we haven't, as I mentioned, this was specifically motivated by this trial and therefore set up to look at the outcome that we had in hand. But again, if talking about the literature, there are only 2 trials that we found which has used this two-stage testing strategy. And if I'm correct, it was not in that area. But yeah, so I'm not really sure how to sort of extend that approach, but I'm sure you could have some extensions into it here.
Into that area. Great. Thank you. And anyone else got any other questions? I know we've only got 2 minutes of questions anyway. I did have another one, Enrica, as well. Just with that, I know, so you said with the p-value of 0.1, is there any sensitivity type analysis that you would do around that, or is that quite a conservative kind of cutoff that you've got there?
Yeah, I think it's a conservative cutoff we've determined at the time of designing our protocol. But, and again, this is something that we are thinking of implementing as well, looking at some sensitivity cutoff points as well, but I am not sure how that would impact, or to what extent it would really impact the results.
Yes.
Again, really, because of the very limited guidance in the literature, we are kind of looking at all these approaches, but also because we need to advise the DSMB, we can't look at a lot of different scenarios as well. So yeah, so that's definitely something that we're considering.
Great. Okay, excellent. Thank you.
Thank you.
Okay, if anyone else has any other questions, we might move on. Thank you, Enrica, that was great. Okay, so now we have so now we've got Vanessa Paksu, and she's going to be speaking about days alive and at home. So overcoming statistical challenges in analysis. So over to you, Vanessa.
Thanks, Sean, for the introduction. So I will share my screen. So can everyone see my screen?
Yes, thank you.
Thank you. So hi everyone, I'm Vanessa, and today my presentation is about days alive and at home and overcoming the statistical challenges in the analysis. The surgery and other interventional procedures aim to relieve symptoms and prolong life. However, surgery is not risk-free as complications can occur. So clinicians need to consider the patient's experience of their illness, quality of life and functioning, post-operative readmissions, and death after hospital discharge. Days alive and at home is a readily quantifiable measure which incorporates hospital stay following the index surgery, hospital readmissions, post-acute hospital discharge to a rehabilitation center or nursing facility, and early death after surgery into a single metric. Days alive and at home is a valuable endpoint for perioperative clinical trials and quality assurance because it is patient-centric. The days alive and at home is calculated from the date of index surgery, defined as day 0, until the follow-up period after surgery. At post-operative day 30, days alive and at home ranges between 0 and 30, with lower values indicating less days alive and at home after operation. So for the calculation of days alive and at home at day 30, if a patient dies within 30 days of surgery, irrespective of whether they had spent some time at home, days alive and at home is scored as 0. If a patient is still in hospital within 30 days of surgery, days alive and at home is also scored as 0. However, if a patient has returned to their original level of care from before the primary operation at day 30, and the patient has not required any hospital readmission, days alive and at home is calculated as 30 minus the cumulative duration of original admission, which includes acute and subacute care. If a patient has required subsequent hospital admission, we will also deduct the duration of subsequent hospital admission. So I will be using the IDOC study as an example, where the primary outcome of the study was days alive and at home at day 30. The IDOC study is a cohort study with the hypothesis that iron deficiency is associated with worse post-operative outcomes than an iron-replete state in adults without anemia undergoing elective cardiac surgery. So this slide summarizes the study design. So adult patients without anemia were screened following listing of elective cardiac surgery at 2 hospitals in Melbourne. We identified non-anemic, iron-deficient and iron-replete participants using the results of routine preoperative blood tests. 240 participants were recruited in each group, and the participants had surgery and followed up at post-operative day 30. So I will be using the IDOC study to illustrate the analysis for days alive and at home and the statistical challenges and solutions for the analysis. So the figures display the distribution of days alive and at home for each group. On the left, we have the iron deficient group, and on the right, we have the iron replete group. The distribution of days alive and at home does not follow a normal distribution. It is left skewed with a spike at 0. There was no patient with days alive and at home equal to 30, but that is because patients are not discharged on the same day they have surgery. They have to stay in hospital for a few days after having cardiac surgery. So here we have fitted a linear regression model to show why the model is not appropriate for days alive and at home. Figure 1 shows the QQ plot of residual, and we can see that the points deviate from the reference line. In figure 2, the figure shows the plot of fitted values against residuals. So there is a cone-shaped pattern in the plot, which suggests that the data is heteroscedastic. From these figures, we can see that the normality and homoscedasticity assumption with linear regression are not met. We also considered a log or square root transformation of days alive at home. However, the assumptions with linear regressions were not met. To analyze days alive and at home, we used quantile regression, which is a technique that allows for understanding the relationship between variables outside the mean. Given the asymmetrical distribution of days alive and at home in both groups, it is more relevant to model the median that is closer to the major distribution mode and directly interpretable. So when using quantile regression, no assumption on the true distribution of the endpoint is required. For the analysis of days alive and at home in IDOCS, the estimates and 95% confidence intervals at the 25th, 50th, and 75th percentiles were obtained by bootstrapping with 1,000 replicates. So bootstrapping is a resampling technique where one treats available data as the population and randomly samples with replacement from this data to generate new sets of data that are more or less similar to the original sample. So we have previously seen that the error distribution is heteroscedastic. So the reason why bootstrapping is preferred is because the standard errors appear to be understated in the presence of heteroscedastic errors if we do not use bootstrapping. Also, the bootstrapping approach does not rely on the underlying distributional assumptions. So the analysis of days alive and at home in IDOCS was done in Stata, and all reported 95% confidence intervals, and p-values are two-sided. So we modeled days alive and at home using two models. In the first model, we included group with iron replete as the reference group and the recruiting hospital, which we refer to as the unadjusted model. In the second model, we included group, recruiting hospital, and potential known confounders, namely Euroscore2 and body surface area, which we refer to as the adjusted model. So the table shows the number of participants with days alive and at home data. It also shows the number of days alive and at home for each group at the 25th, 50th, and 75th percentiles, as well as the difference between groups in the unadjusted and adjusted analysis. So the results suggest there was no difference between the iron deficient and iron replete participants in those percentiles. So the figures displays the difference in days alive and at home at every 5% quantile level with the 95% confidence limits. So this figure is based on the adjusted model. The confidence interval includes 0 at every level, which suggests there was no difference between the iron deficient and iron replete group. But to conclude, the distribution of days alive and at home is left skewed with the spike at 0. Therefore, it was more relevant to model the median than the mean. The assumptions associated with linear regression are not met for days alive and at home. So we use quantile regression, which is a technique that allows for understanding the relationship between variables outside the mean. And it was recommended to use bootstrapping, as resampling methods are recommended to obtain the confidence intervals. And these were the references that I used for the presentation.
Great.
Thank you.
Thank you, Vanessa. That was great. I'll just go over to the main hall. Okay, so no questions there yet, but please feel free to post any. Vanessa, I've got a couple. Thank you. That was really good. It's really interesting. I hadn't heard of that days alive and at home measure before. And I was just curious, where has that come from? How has that developed? Do you know, is it something, who developed that measure?
I think it was developed from clinicians working in anesthesia.
Anesthesia, okay. Yeah, that's really helpful. Thank you. Okay, and I guess my question around that is, because it was, you said it was, well, we saw from the distributions that it was quite left skewed. Is that for specific, and I might have missed it, is that for specific surgeries, or was that a combination of different types of surgeries? And would you expect it perhaps not to be skewed in other surgical cohorts, or is it the consensus that it's generally pretty skewed in surgery, full stop?
I think in general it is a skewed outcome.
Okay. Great. I don't know if anyone else has any other questions. I guess the last one I might just ask is, are there any sort of other assumptions with quantile regression? Are there any sort of assumptions or downsides that you see to using quantile regression?
I think because that method, it does not rely on the assumptions of linear regression, like the linearity, normality, and all the other assumptions, that makes it a good technique to use.
Yeah, okay.
For the analysis.
Yeah. Okay, excellent. Thank you, Vanessa.
Thank you, Juan.
Okay, so we might move on to our next presentation. So next up we have Melissa Middleton, who is going to be presenting on combining multiple imputation and inverse probability weighting to address intermittent missing data in longitudinal studies with missing outcome data. So over to you, Melissa.
Thank you, Sham. So as Sham mentioned, I'm going to be talking about how we can handle missing data in longitudinal studies where we have sporadic missingness as well as missingness in our outcome. So the motivation for my work has come from the paper that's shown on the slide here. Now in this paper, 53% of the children were actually missing the outcome, 42% were missing the exposure, and 12% were missing at least one of the covariates used during analysis. So this is quite a large amount of missing data, and this is actually common in longitudinal studies where we do have these repeated waves of assessments. And what we see is that as we move through a longitudinal study, participants tend to drop out, and measures variables that are measured at later waves, such as our outcomes, tend to be missing in these large proportions. But we can also have sporadic missing data in our exposure and covariate variables from earlier waves. Now we do need to think about how we handle this missing data during analyses. And so now I'll just talk through a couple of the methodologies that we can use. So the first is the complete case analysis. So here we're discarding any observation that has any missing data. So this is quite inefficient and can actually introduce bias in some settings. The next approach that I want to talk about is inverse probability weighting. So here we are still discarding those incomplete participants. So it's still inefficient, but we are weighting those complete participants or that complete data by the inverse probability of that participant giving complete data. So this is really good when we are handling large proportions of missing data, but it's not actually that great for sporadic missingness that we're seeing here in our exposure and covariates. Another approach is multiple imputation. So in this approach, we are imputing the missing values multiple times and combining results from analyses on the imputed data sets to have a single estimate for our association of interest. Now, multiple imputation is really good for sporadic missing data. However, when we have these large proportions of missingness, like we have here in our outcome, we can actually introduce bias. So because of these issues, in 2012, Seaman and co. suggested actually combining multiple imputation and inverse probability weighting. So in this approach, we use multiple imputation to address the sporadic missing data, but we wait for those larger blocks of missing data, for example, our outcome here. However, this approach hasn't been explored in the context of a longitudinal study with dropout. And that leads to the purpose of my work, and that was to evaluate this combined use of multiple imputation and IPW to address that sporadic and outcome missingness in longitudinal studies. Now, within this combined approach, we also need to think about something that we refer to as imputation model compatibility. What this simply means in this context is that the weights from our analysis model need to be incorporated into our imputation model. And it's a bit unclear how to do that, so we did consider two different approaches for incorporating those weights, and I have them listed on the slide here. Now, to evaluate our approaches, we conducted a simulation study, which involved running 2,000 replications of 32 scenarios where the data was drawn from known distributions. And we obtained these 32 scenarios by varying a number of factors that I've listed on the slide. And each of the approaches were evaluated in terms of the bias of the point estimate, as well as the error in the model-based standard error relative to the empirical standard error. Now, for the results, I'm only going to focus on 4 scenarios due to time. But here we have the relative bias in the point estimate shown as a percentage of the true value. Now, I'll talk through this figure. As we go down the rows, we have our 6 different approaches. And as we go across our columns, we have the scenarios with a small sample size and low levels of missing data, then small sample size and high levels, and that's replicated then for our large sample sizes. And just a reminder here that the darker the color, the worse the performance we're thinking about. So a couple of things to highlight is our complete case analysis and one of our combined MI-IPW approaches are showing these large biases in the point estimate, and this is worse in high levels of missing data. Our IPW approach is also showing bias when we have small samples and high levels of missing data. Looking now at the relative error in our model-based standard error, shown here as a percentage of the empirical standard error, we can also see that IPW is showing poor performance when we have small samples and high levels of missing data, and that other combined MI-IPW approach is showing poor performance when we have high levels of missing data. So bringing all this together, we have our complete case analysis and the combined approach had the worst performance across all the approaches that we considered when we had low levels of missing data, and that the combined approach actually was biased in either the point estimate or the standard error when we had high levels of missing data. IPW alone performed poorly in small samples with high levels of missing data. But what we did actually see is that consistently across all the scenarios, MI alone had the best performance. And that leads to our recommendation that MI alone should be the preferred approach when addressing sporadic and outcome missingness in longitudinal studies. Thank you.
Thank you, Melissa. That was excellent. Nice and clear. Thank you. I think with the 2-minute talks, we don't necessarily have time to go through the questions now, but if anyone's got questions for Melissa, please post them on Slack, and I think Melissa can attend to those later. So thank you. Okay, so the final presentation for this session is from Fernando, who will be discussing or presenting distributional regression modeling, a new way of looking at data. So over to you, Fernando.
Yeah, thank you. Can you all see the screen?
Yes, thank you.
Yeah, okay, excellent. So distributional regression, a new way of looking at data in 5 minutes. So I tried to make it as engaging as possible. So the current reality is that data tends to be shown in this way. So I'm just putting a mock example. It's a typical data set that you find in R, and that's a typical way to present data using bar plots. And actually, just as a little side note, there is a movement, so to speak, called hashtag ban bar plots. You can look it up on Google and you'll see what you find. It's interesting. Okay, so some progress when people start showing the error bars, as we can see here. Well, that's an improvement, so to speak. Better yet, we see the error bar plus the actual observations. That's more informative. However, that's not the best way to go when it comes to continuous data or numeric data as a dependent variable. An optimal way is actually to present the ECDFs, the empirical cumulative distribution functions, because this one shows you the actual distribution of the data, and you can see a location, for example, the median, and you can see the other quantiles, and you can see some of the spread too on the shape. And actually, this one is actually an approach that is visually close to this, to what Vanessa was talking about. She was talking about quantile regression. This is a way to present data in relation to a particular approach. All right, so there is a world beyond means, and there are always estimators of location, like for example, median, but there are also other estimators of scale and shape. So for many years, researchers in several fields have been featuring their usual arithmetic mean as the measure of data's location. Also, methods that you see in most cases or most analysis are just t-test, ANOVAs, which are variations of the general linear model. And that's what you see in practice, which is fine. However, there are improvements, and that's why I'm talking about distributional regression methods. Interestingly enough, people talk about group differences when they use a t-test, but in reality, is differences between groups means. Something to clarify there. Seems like nitty-picky, but actually that's the reality. So just to visualize what I'm talking about, we have, this is a group, and the red dots symbolize the mean. So we talk about mean differences, not group differences, okay? All right, so the mean and the associated standard deviations are fine for normal data. And these are, in fact, the most efficient estimators for normal data. If you are dealing with normal distributed data, so the mean and standard deviation are just fine. However, in practice, data are very unlikely to have a normal distribution. That's the reality. And I can tell you this by my own experience analyzing data in cognitive neuroscience. So we have reaction times, we have proportion data, we have functional data like ECG, EEG signals, ERPs also is called ERPs, event-related potentials. These data are never normal. I mean, if you find a normal distribution, that's like finding like a unicorn. So it's not really common to find, to be honest. So that's why I'm favoring this approach, which is called GAMS. As you can see here, that's what it stands for. Generalized additive models for location, scale, and shape. Actually, this paper is from 2018, but the first paper came out in 2005. So some years have passed, but people haven't been catching up with this technique. So that's like, this paper actually gives you like a good snapshot of the technique. Just to show some shapes of data, just to show you the typical cases that we see, similar location, similar scale, these two lines here, the case of similar location, different scale, the red and blue, and these are different shapes that data can take, positive skew, a negative skew, or just uniform. And just to give you some examples of what GAMS look like, this is a typical linear model. This is what you do if you have a generalized additive model, another version of the additive model, and this is the GAMS modeling. And this is like a visualization of how GAMS sits within the whole spectrum of linear models, generalized linear models, generalized additive models, and GAMS. So the last 2 seconds, if you are keen on GAMS, just send me an email and we can talk about it.
Great. Thank you, Fernando. That was a nice sneak peek into that. Thank you.
No worries.
Okay. So I think that's it for this session. Thank you to all the speakers. That was wonderful. I believe we'll be going to a break shortly and coming back. Is that correct? What's the time now? Let's have a look. A short break. Oh, we might not be. I'll hand over to Daniela, who might be able to inform us what we'll be doing. But thank you all to the speakers. That was wonderful.